Welcome to all of you as you're coming into the room, and we'll just be a couple of minutes as we get everybody settled into their seats, so to speak. For those of you settling in, just a reminder that we're in a Zoom webinar, which means your camera and microphone won't work unless we send you a specific message asking you to unmute. And Dr. Sammy and I will be taking questions in a Q&A after her presentation. And there is a Q&A button somewhere on your screen, whatever kind of device you're using. And we'd like to encourage you not to post questions in the regular chat button. They can get missed. It can get really busy, and we want to make sure we can get as many questions in as possible. So if you have a question to pose for the Q&A or a comment, please use your Q&A function button. If you desire to use closed captioning, click on the CC button on your screen. If you experience any challenges with that working, let us know, in this case through the chat, and our tech support will seek to address that. We'll just let this sit for one more minute, as I do see there are still a few people coming in. And then I will introduce the Palliative Care Society of the Bow Valley and the reason that we've all come to this virtual space together this morning / this afternoon. I think we actually have participants across quite a number of time zones. So we probably have some joining in at 10 o'clock BC time, and a few that are here at 1, or possibly, I guess, Maritimes would be 2 o'clock your time, wouldn't they? Yeah. All right. Well, welcome to all of you who've joined this conversation. My name is Bill Harder. I work with the Palliative Care Society of the Bow Valley, and I have the privilege of being one among many across this country and worldwide that do the work of journeying along people who have received the hard news of a diagnosis of a life-limiting illness. The work of the Palliative Care Society of the Bow Valley, we call ourselves PCSBV, begins to unfold as we gently step into those spaces of people's lives after a diagnosis and into that very human, beautiful work of dying. When the path is uncertain, we walk alongside those in this transformational journey, finding a way forward. At PCSBV, we offer essential programs and services to those in our community, experience life-altering circumstances, including diagnoses, chronic conditions, and of course, all kinds of levels of grief. Your generosity has enabled us to provide much-needed support and solace to meet the needs of families. And together with our valued partners across this region where we are, that being Lake Louise, Banff, Canmore, and the Stoney Nakoda community of Morley, we ensure individuals and families can navigate the palliative care system smoothly, keeping in mind Alberta Health Services, home care, and Covenant Health. But enough about us. We've gathered to turn our attention to our very special guest joining us today. As part of our work, we host these special speaker series to help change the dialogue about dying, death, and grief, and to imagine how the experience can be different for patients and their families, positively different. As part of bringing these topics forward in new ways, we have speakers like today's guest, Dr. Sammy Winemaker, to speak with us and provide thoughtful, well-informed perspectives to this table of conversation. And with that, it's my distinct pleasure to welcome and introduce Dr. Samantha, the Sammy Winemaker. Dr. Sammy is a palliative care physician who cares for patients with serious illness and their families in the home. She's an associate clinical professor at McMaster University in the Department of Family Medicine, Division of Palliative Care. She is the medical co-lead of the Hamilton Community Palliative Care Team and an active trainer of palliative care education to medical students, residents, and clinicians. So thank you for being with us this morning or this afternoon, depending where you are. And we are looking forward to hearing this presentation from Dr. Sammy. Dr. Sammy, take it away.
Okay. I never dropped the name Sammy. It's been with me my entire life. And when I graduated, I tried to be Samantha. And it honestly didn't feel like it felt like me. So I'm still Sammy. I know that's funny. Anyway, thank you so much for having me join this speaker series. I'm so excited to get to know all of you who belong to the Society in the Bow Valley. I wish I was in the Bow Valley right now. I hear you have beautiful snow on the ground today. And yeah, thank you. Thank you for coming today. So the title of the talk today is Imagine Improving the Illness Journey. It's not imagine improving the end of life or imagine improving dying and death. It really is imagine improving the whole entire journey for people who have been diagnosed with a progressive life-limiting illness. We really need to think about improving the beginning, the middle, and then naturally the end might be better. So that's what we're going to imagine today. Okay. This is my care setting. It's incredible. I work in the community. I work in people's homes. And in people's homes, people are themselves. And that's a really exciting place to be as a doctor, because you can see how people are living and dying with their progressive life-limiting illness, with all the color and texture that surrounds people's experiences. And I feel that I have been so fortunate for 19 years doing this work in people's homes that I've been in this big, exposure to people's stories, real stories. And it's given me a perch at the end of life in people's homes that has shone light on what their illness journey has been like before I ever met them. And so working in people's homes is like no other care setting, and it's my absolute favorite. However, I will share with you that most of the patients and families that I meet, who are usually referred to our outreach team at the very end of an illness journey, I find myself scratching my head. Why are people so lost and confused, perplexed, bewildered? Of course, this is the end-ish of the journey, and they would have had so many other healthcare touch points before I come into the home. And so why am I entering onto the scene and people are feeling so discombobulated? So I had to learn pretty quickly how to do what I call the 11th hour scramble and ask myself, why is it that I'm doing this? I mean, I don't mind doing it. I love doing it. People benefit from it, but why me? Why at the end? Why am I inviting people to understand their illness better? They may have had an illness for 10 years, for 5 years, for 2 years, for 1 year. And I'm the one in there at the end, helping them to understand their diagnosis, help them understand the big picture and the long view of their illness, where they're at in their illness story, what to expect from here forward. Sometimes we talk about a timeline, what supports are available, what teams, they have all these different teams, who's on first and who's on second, and we try to weave a string between everyone, and the role of their family and what that's going to look like from here forward. We talk about what hurdles might come our way in the next chapter of their illness and how to put in action plans just in case things go a little bit sideways and who to call for what. So this is what I do in people's homes. When I graduated, I thought I was going to be this incredible symptomatologist. I was going to help with symptoms, and, basically that was going to be most of what I do. And yeah, I do some of that, but I will tell you, most of the time, I would say 99% of my time is spent with this kind of stuff, really helping people understand their situation. So again, I scratch my head because I can't understand why I'm so late in the game and people are so foggy about these things. So what I did is I decided to put myself in a clinic. I won't tell you which clinic. Okay, it was a heart failure clinic, and I won't tell you where though. But anyway, I invited myself into a clinic where people have advanced heart disease, heart failure, and I spied on them. I don't know why they let me come, to be honest with you, but they did. I said, I'm a palliative care doctor. I'd like to come and see what's happening in your clinic, because I wanted to see, before I get people, whether they have cancer or lung disease or liver disease or kidney disease or dementia or whatever illness, progressive illness they have. I wanted to know, what does this story look like before I get involved? And why am I receiving patients so discombobulated? And what I found was that major themes bubbled up. And I bet you any money that if I had put myself into a Parkinson's clinic or an ALS clinic or a COPD clinic or a cancer clinic, I am positive the same themes would have bubbled up, which helped me to understand what's the problem here upstream, that downstream, all of my patients are so confused. Well, the major themes were, in the clinic, they were very busy, and mostly the focus was on the weeds or the acute issues or the details of the illness. So for example, what's the potassium level? How much Lasix should the person get? What does their ECG show? They talked about medication changes and, micromanaging all of these very important things. And the patients and families were sitting there sort of nodding their head, being good patients and families. But really, there was a lot of busy details going on, all important, but without the overarching offering of where this person's at in their illness. So all of these decisions being made in the clinic with no context. Patients and families were not offered the forest. Like, let's talk about the fact that you have heart failure and you've come today, and these are the things that we have found today. You might wonder what that means in the context of your heart failure. Remember, the last time you were here, we talked about the early chapter of heart failure. These changes we're making today, you may want to know where you're at in that heart failure journey. So that was one of the major themes, is that big overarching roadmap of the illness was missing. And so, of course, people are just, micromanaging things. And by the time I meet them, they haven't been invited into this big picture discussion. Also, I saw a lot of amazingly positive healthcare providers cheerleading. Okay, Mrs. Smith, you look great today. You've come out of the ICU and your cheeks are pink and you look so great today. But really, Mrs. Smith hasn't bounced back to where she was at. And she's probably thinking, okay, I don't feel so good. Why are they so positive and cheerleading? And so I noticed that there's a lot of toxic positivity happening in healthcare, which is well intended, but not balanced by the reality of the person's situation too. That healthcare providers were having trouble walking two roads of hopeful positivity and infusing some reality into the illness at the same time. They were definitely missing cues from the patients and families. Patients and families were taking a back seat in the shadows a little bit, and they were quiet and polite, and I could see from facial expressions or the way they were sitting that the clinicians in the clinic weren't picking up on really probably what's on the minds of patients and families. Definitely, they were operating in an old-fashioned model of palliative care where they were cheerleading, 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 cheerleading. And then there's going to be a point where they say, oh, there's nothing more we can do for you. I'm going to transfer you to palliative care. And that, I'm going to explain, is a really problematic way to look at palliative care. And another thing is that in the specialty clinics, sometimes they don't really understand how to work with primary care providers or family doctors. And so by the time I meet patients, they really don't understand, okay, well, what's the role of that person? And what's the role of this person? And they don't see these pieces being woven together in the clinics. And so these major themes helped me to understand or confirm to me why people are so fuzzy about their illnesses, even by the time they get to the very late stage. Sometimes they don't even know they're in the late stage. They think something's not right, but they don't even know it. And then we're scrambling, doing that 11-hour scramble right at the end. So here's the old model of palliative care, okay? So this is a diagnosis, okay? Right here, we've got a diagnosis here of a progressive life-limiting illness. Could be dementia, could be ALS, could be congestive heart failure, COPD, pulmonary fibrosis, liver cirrhosis, chronic kidney disease, could be an advanced cancer. Whatever it is, at diagnosis, there's lots of focus over time on modifying that disease. We're going to try our very hardest to slow that illness down as best as possible. Sometimes we call them chronic illnesses, which is a real misnomer because all of the diseases or illnesses, the diagnoses that I mentioned before, they're not just chronic. Chronic means they last for a long time, but they're not just chronic, they're progressive. They change over time. They go from the early to the middle to the late stages. And so really this should read progressive and life-limiting illness. But what we do is we say, rah, 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 we're going to do treatments. We're going to do first line, second line, third line, fourth line, fifth line treatments. And we're going to do all of this stuff until there's nothing more we can do for you. And right this purple star right here, we're going to label you palliative. You're palliative. And then you get transferred over to this death squad, the palliative care service. That's how it feels. It feels like I was getting very active care here and everyone was, cheering for me. And then suddenly I'm labeled and I become this thing called palliative. And then I'm transferred to another team. This is very problematic for lots of reasons. One of them being that this label of palliative means that, oh, maybe before this weird point in time, we didn't really have to talk about the fact that this illness was changing, that we knew that Parkinson's had a certain pattern to it, that COPD has a certain pattern to it. This allows us to pretend like nothing's going to change until this weird point in time where someone's labeled palliative. We didn't have to have advanced care planning conversations. We didn't really have to take our blinders off until suddenly the carpet's pulled from beneath someone and they're labeled palliative. So this is a very, very problematic model, and it is still alive and well in most of our healthcare environments where we transfer the care from active care to your palliative kind of care. Gotta go. So what does it mean in this old-fashioned model when people are labeled your palliative? Well, for many people, it feels like the healthcare system has given up on them, that they're being abandoned by the people that they've known for so long in their healthcare journey, that there's no more hope, and that really there's no more active care for me. I guess I should just give up. And most people equate the word palliative with pain. And so I guess I'm really dying now, and I'm just going to wait for the pain to come like an onslaught out of nowhere. This is a more modern way of thinking about this idea of palliative, a palliative approach. This model is an integrated model of palliative approach, where we have a diagnosis, the ones I mentioned before. And in the beginning, after the diagnosis, certainly there's lots of care to try to modify whatever disease that is, or whatever illness or diagnosis. But at the same time, we begin to infuse a palliative approach along the entire journey. That might be just little bits at the beginning, but over time, increase in proportion as the opportunity to slow down the illness gets less and less. And you can see that this is a dotted line here because this is fluid. It's a dance that all healthcare providers should be able to do naturally without ever labeling someone palliative. A palliative approach is a philosophy of care that should be infused and peppered into the entire healthcare journey so that along the entire way, there's this beautiful balance of hopeful care and reality-based care, that the two can walk side by side and not dishonor each other. And then even after a person dies, that a palliative approach means that we care for the bereaved as well. And so this is what is more modern way of looking at palliative care. It's not a point in time. It's not a place. It's not a new weird diagnosis. It shouldn't be a label. It needs to be a philosophy of care, an approach to care. Sometimes it's a specialty, but mostly it's the type of care that all healthcare providers should know and learn how to do in their training and see it role modeled all over the place without having to label someone. It makes a lot of sense because when you look underneath the word palliative, it really just means supportive care, comfort care, not just at the end, along the entire way, the entire illness journey, needs-driven care, person-centered care, comprehensive care, continuous care, whole person care, good care, honest care, reality-driven care, care for serious illness, whatever synonym you want to use. This is not meant to be an approach that is reserved for a specialist to come into someone's home at the 11th hour and try to do all of this at the end. Sometimes I worry that the way I've been positioned as a palliative care specialist in this picture of an illness journey is almost like a cleanup crew, that as a patient's gone through their illness, that they have been almost metaphorically broken apart, and that a palliative care specialty team at the very end tries to stitch them back together with all of this care that's on this slide to send them off feeling like, you know, almost like customer service, like they got a good journey. That's an unfair way to move through a progressive illness. All of this that's on this wheel here needs to be part of the care journey from the beginning through the middle into the end parts. So, you know, we do definitely need a public health approach to raising awareness to the population that dying is a part of life and that every single one of us will die, and that most of us, 90% of us, will die from something like a progressive life-limiting illness. Only 10% of people will die suddenly from some kind of accident or lightning or a car accident. Most people will die of something. And so we do need our public health colleagues to say, you know, yep, we've done a great job teaching about seatbelts, and we've done a great job teaching about wearing bike helmets and protecting yourself from sexually transmitted illnesses. And we've done a great job talking about vaccines and whatever, but we need them to do a great job at helping us from the time we're born understand that we live and we die, and that's the bottom line. Some of the things that are problematic currently with this serious illness journey are these assumptions like, oh, the doctors know everything, or patients have to be good patients. They have to be passive and sort of polite, because if they're that way, then they may have a better chance at a better illness journey. That patients assume that they'll be given information when they need it, and that's not the case. I'm going to go into that. Patients assume when they have a diagnosis that they no longer have any control, that it's the illness that's going to dictate how things are going to unfold. And many people, because we're a death-denying society, for the most part, believe or don't entertain the idea that they will die. And they're forced into this, I'm going to beat it. I'm going to have a stiff upper lip, and don't worry, I'm going to be the first one, and da, 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 da. And it's a lot of pressure to operate that way with the progressive illness. Most people think they're going to die suddenly in their sleep and don't realize that dying is actually a chapter. It's not a moment in time. It's not the last days. Dying happens much before death, and everyone assumes that dying is painful. And so what we need to do is make sure that we do a better job at explaining to people that most of us will get something at some point. Like I said, 90% of us will go through a period in the last chapter of our life where we have some diagnosis, or we get frail from being older, but we won't just die like a snap. That we all deserve information right from the time of our diagnosis. That even though if I get a diagnosis of ALS, it is, for me, the first time I'm ever going to go through ALS. ALS is a well mapped out illness. It has a storyline to it. It has certain bus stops or milestones or major decision turning points. And I have the right, as a person diagnosed with ALS, to this information as my roadmap going forward. What I don't want is to be blown left, right, and center as a passive, polite patient through the healthcare system that's uncomfortable with the reality of my illness until I get to a point labeled palliative, and then people are scrambling to invite me into the reality of the illness. We all deserve information right from the start about what's going to happen with our illness if we want it. We need to be advocates in the healthcare system. We need to know that there isn't anyone that's going to show up and teach us how to be a patient when we get our diagnosis. It is a new role for most of us, or as a caregiver, that we need to advocate and learn and access information as best we can, as early as possible, so that we're not downstream feeling very overwhelmed and at that point having to advocate in a crisis. The truth about a serious illness is that most people, when they go through a serious illness, even if they've lived mostly solitary life for the first few chapters, by the time we get to the end, it's really difficult to go through dying without an inner circle of people around you. And that's not something you want to learn right at the end. It is possible for people to remain hopeful and informed throughout an illness journey. You can hope and be truthful and realistic and access information about your illness and remain hopeful the entire time. Hope looks different at different points of the illness journey. It evolves from hoping that this is all a big mistake to hoping for different things. And even right until the end, people can continue to hope that their family is okay and that their children will grow up. It's still it's still hopeful. It just changes over time, as long as a person has realistic information about their illness journey. Like I said, the big aha moment for everyone is dying is a chapter in life. It's not a point in life. That's dead. Dead is a point in life. Dying is the precursor. And depending on who you ask, some might say dying starts the day we're born. Some, when they say dying, think of the very final days of life. But really, dying in most illnesses begins to happen in the last year of that illness. And it can be a very comfortable process, dying. So one of the things that I spend a lot of time doing is helping people understand the illness trajectories. As a medical system, we have forgotten that these illnesses are well mapped out. Cancer has a well mapped out illness journey, heart disease, lung disease, motor neuron disease like ALS, frailty, dementia. Billions and billions of people have had these illnesses. These are just stick figures up here. There's a lot of meat and clothing we could put on these stick figures. We could talk about what does the average storyline of heart disease look like, lung disease, Parkinson's. I keep naming these things, that these illness trajectories have been forgotten. We get so busy in the healthcare system dealing with the nitty gritty, the acute and episodic issues, that we don't offer this amazing information that we have about all these illnesses, like I said, that functions as a roadmap for people, patients and families who feel that they have no anchor, that they're scared and worried and up at night because they don't know what to expect. It's because many are missing this important architecture, the context of their illness, these chapters and what they look like. And so I spent a lot of time thinking and planning and teaching around the big picture of the illness, because I personally believe it's very difficult to make decisions while you're in an illness if you really don't have that context. And the biggest problem is that if we pretend like dying is not going to happen, that these illnesses are truly just chronic, and then at some point, oops, there's nothing more we can do for you, and you're palliative and you're going to die, we actually do people a huge disservice, because essentially we turn what should be an expected dying and death over a period of time into what feels like a sudden lightning bolt for people. And when people suffer from what feels like a sudden death because we didn't bother inviting people to know more about their illness, and suddenly they're scrambling, it's unanticipated. People are unprepared. They're shocked. They don't cope as well when things are sudden and acute. There's lots of emotion, no time for goodbyes. There's unfinished business and disbelief and complicated grieving. When we turn a story of, I'll just say ALS again, which is something that has a typical timeline to it, that we know has chapters, including a dying chapter. If we ignore all of that and suddenly someone runs into trouble at the end and they're in the ICU and they get ventilated and they pass away, that is going to feel like a sudden death to the family. It was an expected death that could have had a different rhythm to it. And an expected death, you can harness the benefits of time, even though it's not news people would want. Humans are incredible people. No news is the worst thing people could have. It's worse than having bad news. If people are invited to gently understand their illness journey and where they're at in their illness, they have the ability to harness the time. It's their currency. Whatever they want to do with that time, whether or not it's 6 months or 3 months, 1 month or weeks, it's theirs to have, not ours to have by pretending this is a chronic illness with a sudden death at the end. When people anticipate that dying is going to happen, then they can move through the hope journey, like I explained, but they can also move through the grieving journey before they die. It's called anticipatory grief. And it's a really important coping mechanism for patients with the illness and family members. That when we balance hope and reality, people can begin to grieve and begin to adjust to the different hurdles that are going to come. Expected deaths mean we can have the opportunity for personal growth, finding meaning and closure, maybe reconciliation, maybe receiving or granting forgiveness, and maybe an opportunity to say goodbye. So it's all hands on deck, really, that we really need to do a better job when people have a diagnosis with a progressive life-limiting illness. We need to make sure they're invited right from the beginning to know as much as they want to know about what this illness is going to look like at the pace that they're ready to get information. And we need to go full steam ahead and say it's not acceptable to graduate healthcare providers without knowing how to naturally infuse a palliative approach into the entire healthcare journey so that we can move from that old-fashioned, old way of thinking about palliative care as a label at the end to the new type of palliative care where everyone is doing it without having to label it necessarily. And it just becomes a natural part of journeying with people. All healthcare provider, all curriculum for healthcare provider needs to be rejigged so that we can make sure that people graduate in healthcare with this skill set and that it's not reserved for a palliative care specialty team right at the end. That's too late. It's better than nothing, but it's too late. We can do better. We can imagine that it can be better. What I have imagined is that while I will spend much of my time trying to teach as much as I can healthcare providers about a palliative approach, I have imagined that patients, families, people, citizens, public, not healthcare providers, can begin to learn from what I have learned at the end of life. They can begin to be taught a new way of being a patient and family, one that is not in the backseat of their journey, but to learn how to come forward when they get a diagnosis of a progressive life-limiting illness, that they can leach out of the healthcare system that's uncomfortable a palliative approach without ever having to label it. I imagine that there is a way that the population can get what they need without having to be at the mercy of an uncomfortable doctor or an uncomfortable nurse that's struggling, inviting people into these questions. And so what I have done is I have partnered with my incredible colleague, Dr. Cien Cial, and we said, enough. We can't keep these, they feel like behind the curtain of healthcare, dirty little secrets to ourselves. Like this is a broken system. There are lots of things that work in our system, but there's a lot of things we want to climb on top of a mountain and scream to the public, folks, you need some knowledge and skills about how to move through the healthcare system, how to move through your progressive life-limiting illness, or else you're going to end up scuppered at the end, jumping from one puddle to another, feeling like you're always in a crisis. And so we started this waiting room revolution. We called it waiting room revolution because people are literally in a waiting room for lots of their illness and metaphorically in the waiting room, waiting for what they don't even know. Is it a diagnosis? Is it the results of a test? Waiting for someone to tell me what's happening. So we started a revolution, a public-facing revolution. And we came up with 7 keys or 7 skills or 7 bits of knowledge that we fundamentally believe that if patients and families could learn about these 7 things early in their diagnosis that don't scream out, oh, one day you're going to die and palliative care this and palliative care that. No, this is language that is palatable, positive, real, honest, truthful skills that fundamentally will change the journey for patients and families, where along the way, they will recognize themselves. Along the way, they will feel less anxious and worried and scared. They will be in the know instead of in the dark and be able to make truly informed decisions, not just decisions based on half truths or partial information. We are giving them a roadmap, inviting them to have more control over their illness. and therefore more independence. And so I won't go into the 7 skills right now, but they are walk 2 roads, zooming out, knowing their style, customizing their order, expecting the ripple effects, tag your it, and invite yourself. I could spend a whole other talk talking about these things, but I won't. But what we did is we took everything from the end of life, we repackaged it into 7 amazing skills that people will be offered at the beginning of a diagnosis. If you're interested in seeing more of our work or listening to the details of these 7 keys, please, you're welcome to listen to our podcast. You can just listen on any way that you listen to podcasts, or check out our website at the Waiting Room Revolution. And I put some other contact information up there. But to conclude, people deserve to go through a progressive life-limiting illness, feeling like they're driving the car with the healthcare providers alongside of them. But we want people to feel that they are moving through an illness where, the healthcare system has got their back, and that we're not going to hide behind things like labeling things just chronic, or, saying, rah, 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 you can do it. Come on, you've got to fight. And, we believe that the elephants in the room need to be addressed. And we don't force people to know information that they're not ready for, but people need to be invited to know more if that's the kind of person they are. We don't want people to be in the dark. We really want people to be in the know. And we feel that if we can set off a revolution or a tidal wave of a new type of patient and family, that if they rush to the healthcare system with new skills and new questions, that the healthcare system is going to have to change. So this is a social movement, really, that we're trying to spark here, while we still continue to try to change the culture of healthcare from within. So imagine that. That's all I have to say.
Sammy, thank you for really giving us an awful lot to chew on. And we're going to spend a few minutes together processing some of those parts. There's a number of things that stand out for me. I just wrote myself a couple of notes as you were speaking. Earlier mentoring in living and dying. I think of the stories that us in this work have gathered, right? Of somebody whose loved one died and they'd never seen dying before. And nobody had mentored them on what dying is, or what it looks like, or what the body does, or what the mind and the heart of that person do. Mm-hmm. And what a countercultural piece to suggest that we might actually mentor children and youth and young adults and the working age and elders, mm-hmm. in the beauty and the very human work of dying. That just strikes me. What a beautiful statement to give. You also said that palliative care, the palliative approach, is intended to be a natural part of healthcare provision.
Yeah.
And I think, again, that is just wildly subversive, yeah, against what the system that is. Mm-hmm. Mm-hmm. We have our work cut out for us in this conversation.
I'm scared. No.
Yeah, well, we should be.
Yeah.
Anybody who takes on it. That's right. Yeah, for sure. When we engage subversive work, there should be a wee bit of anxiety around that.
Yeah. Like I said, I've had to ask myself, Bill, am I part of a problem here? Palliative care felt so good to me when I first started working, almost like, dare I say, not that I would know, but it felt like a drug. Like, it felt so good to come on the scene when people were so needy and desperate, and I could do my 11th hour scramble. I was addicted to it. It feels so good, but it didn't take me long to start thinking, what am I doing here? What is the problem? Like, this is all good for this one person, but this is not a good news story. People deserve to have some of this along the entire journey, not me along the entire, but this type of information and care. And so it is countercultural to think, let's not just grow the palliative care service at the end of life. We actually have to relinquish ownership over palliative care as a specialty and give it back to healthcare along, like in everyone's business, give it back and not build it as a kingdom that happens at the very end of life. So these are provocative thoughts, and for some can feel quite threatening as well.
Our primary care physicians, our GPs, are so perfectly placed in our lives to be the mentors to us as patients and families, if they're mentored.
That's right. And so right now, I hate to say it, in Canada, we do not have a mandatory curriculum in family medicine training around palliative care. So that's the bad news. So we graduate family practitioners who haven't had the formal training. The good news is, though, that they get training in comprehensive care and continuous care and relationship-based care. And I would argue that that's a big part of a palliative approach, but they just don't see it that way. So if you ask many primary care practitioners, well, especially here in Ontario, do you do palliative care? No, because they were never trained with palliative care rotations. But if you ask them, do you care for people with heart failure, with lung disease, with kidney disease, with, oh yeah, I do that. Oh, and do you care for them across the entire illness? Oh yeah, I do that. Well, guess what? You are providing a palliative approach. So a lot of our problem is language and semantics and labels.
Yeah, the word palliative itself is such a loaded word in our medical culture.
Yeah. Like a 4-letter word, if you know what
Yeah,
I mean.
oh, I do. Yeah.
Yeah.
We don't want to hear that. When you go for your test results on that day to your GP,
Yeah.
you don't want to hear the word palliative mentioned.
No, but if you go for a test result to your family practice, and you end up with a diagnosis, again, let's just pick Parkinson's, just because I'm picking one, then a person who's just been diagnosed does not necessarily want to be sat down and told blah, 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 blah. This is what it's going to look like down the road, and this is what the average timeline is. But a person with Parkinson's in a family practice office can be invited to know that we've cared for a lot of people with Parkinson's before. And if I was a family doctor, I might say, I've had lots of patients with Parkinson's, and I'm in this with you. And I know you're going to have lots of questions, because Parkinson's is the kind of illness that changes. It goes, this way and that way. And it's not the kind of thing that stays exactly the same over time. Okay. And so you and I are in this together. And I want you to know that any small, medium, large, or humongous questions you can ask me. I might not have all the answers, but I want us to have open communication, because I've done this before. Look, I'm not a specialist in Parkinson's, but I've had a lot of patients. So this is what infusing a palliative approach looks like in the very beginning. We're not shoving death and dying in people's faces, but we're beginning to walk that journey with a dose of invitation and reality of what that there are going to be things to consider over time.
Just hearing you say that, and I don't have a diagnosis of a life-limiting illness, hearing you say that brings me comfort. It just makes my being feel like, I think I could do that if I heard those words from my physician. I would feel supported enough in my fear and anxiety about it that I could probably find a way to breathe moving forward. Those are good words.
Yeah. People want to renew their vows with their doctor or their healthcare providers when they have a diagnosis. They want the healthcare system to say to them, I've got you. We got you. We're in this together.
Well, Sammy, I've got a few questions that have come up from our group. If you're open to playing around with some
Mhm.
conversation. And Marianne says, does this approach work for patients and families from every culture? Can you explain if and how you've modified this, i.e. palliative approach to care, for cultures where the patients don't want all the information or where families don't want to talk about death?
Yeah. These are really important and good questions, because every culture is different. I would say every family is different, every person is different, and there is a uniqueness that needs to be respected, right? And so I think from the healthcare providers side of things, we need to be humble and open with everyone we meet. And we need to simply ask every single person, what do I need to know about you to be able to provide you the best care? And that comes from the work of Dr. Harvey Chachanov. And I feel like that takes care of so much. What do we need to know about you in order to help provide you the best care possible? That can be something about you as a person, or you as a family, or you from a particular culture. I think we need to be humble that we don't know and ask people to tell us what's most important to them. And from the patient and family side of things, I am trying to suggest that everyone come to the healthcare system and say something like, doctor or nurse, I'm just saying doctors or nurse, or whatever healthcare provider, this is what I need you to know about me to be able to care for me through this illness. These three things are extremely important to my culture or to me. And I think if we had a spirit where we were all just invited to either learn about or share with, I believe that we would be a lot further along than we are right now. But definitely, it's not a one size fits all. Absolutely. And we know we have marginalized groups who feel very silenced and very disenfranchised with the healthcare system. So, me saying, oh, you need to find your voice, come on, speak up, be empowered, be activated, be assertive, doesn't work for many populations. And so, it's going to be a learning curve. I think I don't really know exactly how to answer this because I think we have a lot to learn and we have a huge culture shift to undertake in healthcare. Huge, embarrassingly huge.
Thank you for that. Yeah, that's a great answer to a very complex question.
Yeah, it's complicated.
And we live in a super multicultural country.
Mhm. Yeah.
And across our country, different subcultures within it. In the Bow Valley, where I am, there's a huge immigrant population that provides wondrous spice and color and experience to this community, and with really unique needs. I'm going to hold on to those words of, we need to ask that question.
Yeah.
What do I need to know about you?
Mhm.
Another question, do you have advice about helping a person with dementia deal with grieving?
The patient with dementia, with grieving. Okay. Ooh, that's tricky, right? So, like I said before, grieving ideally starts before a person is gone, right? And a person who's diagnosed with dementia, when they still have reasonable cognitive abilities, is going to grieve that diagnosis. If I was diagnosed today with dementia, I begin grieving that diagnosis. Um, and at the risk of sounding like a broken record, the more information I have about dementia earlier on in my dementia story, I'm still capable and competent as a person to influence what my wishes and my worries are going to be going forward. So I still believe part of healthy grieving, even for someone with dementia, is making sure while they have the cognition to participate and still control what they can, that they be invited to do so. And that we don't just sort of not address the fact that we know that cognition is going to get worse and worse. But the other part about patients with dementia that's tricky is that they forget their diagnosis. I had a patient once who had dementia who also had a cancer. I remember going and not knowing that the person had dementia. In fact, it wasn't on their list, the medical history. I went in and I invited her to know more about her illness, and she said yes. I asked her if she understood about her illness. She said yes. And then I ended up talking about cancer. Oh, I have cancer. And I looked at my information, said, am I the first one telling this? I didn't know she had dementia. So it was shocking to me, and reminder that yes, people with memory issues can forget, A, they have dementia, and B, that they might also have some other progressive life limiting illness as well, because many of them have multiple things going on. And so I think we do have to be very sensitive to where people are at in their dementia story, and really try to tailor the information to address what they're asking of us. So if someone's really not asking more and more and more about the reality of their illness, I don't think we have a responsibility to keep bombarding them with the same information over and over. What do you think, Bill?
Yeah, I appreciate your response. And one of the quirks of the various kinds of dementia that present is that there's a limit to how much information can be processed and how fast it can come at them.
Mhm.
And we have to be really gentle with that, I think, and respectful of what the window looks like that patient is looking out of. Grief is tricky to begin with for all of us. It's hard work being a human griever. And then it's exacerbated when the news is fresh every day.
Mhm.
And
Mhm.
so it requires, I think, a response to that person, somebody in their palliative network that really has the possibility of holding a space with them
Mhm.
regularly for that grief to be the first time,
Mhm.
possibly for days, weeks, maybe even months, where they come and sit with that person and receive that patient's story
Mhm.
again, as if it was fresh for that patient, as if they'd never heard it.
Mhm. Mhm. It
Yeah.
is. It's tricky. It's tricky.
What are your thoughts on primary care physicians talking to their patients about advanced care planning, or at least providing resources to access that resource?
I think it's really important. I think it's extremely important. I think advanced care planning, the first word is the most important, is advance. So it's in advance of having an illness. Um, we can participate in conversations around advanced care planning when we're healthy. For example, I'm healthy. I come home every day. I'm sharing with my husband and my family, not specifics, but the kinds of things that are on my mind. Like, I met someone today and I have to say, if I was in their shoes, blah, blah, blah. So those are advanced care planning conversations that aren't labeled that way. Like I'm sitting down, family, and having an advanced care planning discussion with you. But over a lifetime, even while we're healthy, sharing with the people in our inner circle what's most important to you and what you value is extremely helpful if there's ever a time where they are in a position that they have to make a healthcare decision for you because you're not able to. Like my husband knows exactly the values that I hold very high, so that if something happens to me, he won't make a decision that's best for him. He'll know what I would want because we've talked about it so much, not specifics like I'd want a feeding tube or this or that, but that it's important to me that I can communicate. It's important, my independence. Like these kinds of values are important. And I think that family doctors are in a perfect position to be receiving information like that in case they also have to advocate on behalf of a patient. So for example, if I'm a family doctor and I have a sister and a brother who are both part of my practice, and the brother needs to make decisions on behalf of the sister who's no longer able to, but that sister has told me a lot as their doctor about what was important to them. I'm in a perfect position to advocate for that patient, but also to help the brother make big decisions. And so family medicine, like we already mentioned, is very relational. And it is really important when family doctors are referring people to other types of specialty teams that they can also share this information in their referral notes. Like, I'm sending you a 68-year-old woman with blah, 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 blah. And by the way, it's really important to this person that they have X, Y, and Z. Or, the family doctor can be a really important carrier pigeon for someone's advanced wishes to other touch points in the healthcare system. And people trust their family doctor. They trust their family doctor so much that the family doctor is in a perfect position to bring up these conversations while a person is well at any time. I'm all for it.
Yeah, I'm sort of holding on to these words and thinking maybe it should be a requirement at age 18 or when we get our driver's license or something, that we complete this work of advanced care planning.
Yeah, I know a lot of people that wonder if it should be part of, when everyone turns 50 or when everyone but that it shouldn't be attached to an age. But you're right. I think you said 18, because what you're saying is like, there's no time like being young to start thinking about, again, if we had a public health approach to mortality awareness, then early advanced care planning discussions would just follow suit, right? It would be normal to talk about one day, if I'm ever blah, 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 blah,
Right.
Just know that I need to be able to use my hands to talk. So if I needed to make a decision about my hands, it's really important because I use my hands a lot, that kind of thing.
I'm going to invite PCSBV's CEO, Teresa Radwell, to move into presenter screen so she can come on live. And she has a question for you. And so let's welcome Teresa.
Oh, I think I have to stop sharing.
Oh, maybe. All right. And I do see that she's there. Yeah. So Teresa, welcome aboard, and welcome to all of you participants. Teresa is newly joined our team in August, and she is an amazing gift to the world of palliative care and to our organization. Just thrilled to welcome her and introduce her. Teresa, you have a question for Sammy.
I do. Sammy, thank you so much for your presentation. It's really, I think, is definitely thought-provoking. I think anybody that has personal experience of that palliative care journey probably has far more experience of the traditional approach versus the desired approach, for sure. And I think I personally would welcome that sort of longer conversation around palliative care and dying and death. And Bill spoke of an example of somebody that had kind of almost was afraid to have that conversation, was afraid to know about it and what it meant. I was that person. I mean, I'm not sure if that was who Bill was speaking about, but him and I have certainly had this conversation. It's not something that is openly discussed. And I think as the caregiver, as well as probably from, if I'd known from the patient side, it would have been a much easier conversation to have had. It wouldn't have been such a final conversation. It would have been a discussion, and I think a much better outcome in the end. I kind of feel you spoke about the cheerleader, and I kind of think, yeah, I was guilty of that. And I had somebody in the room here with me as well, and she would say, yeah, I've definitely done that. I say, oh yeah, you look much better, and oh, you look great, and just keep fighting on, and and I think I think again we're all very, very guilty of that that conversation. I want to kind of bring up the subject of MAID, and I think in many camps is a controversial piece, but it is a reality. It is here, and people are considering whether or not this is something that they wish to pursue. And I want to reflect back onto your sort of 7 keys, and in particular number 5, which talks about the ripple effects and the involvement of patients and their family members and caregivers and friends, and that sort of inner circle that you spoke about, that support network. And just to ask whether or not in the process of these sort of discussions in that journey, and potentially within sort of that sort of the grief path that comes with that, do you see differences in the support that you need to give to those sort of individuals that are either providing that support, those family members, with that individual that is considering or has decided upon MAID as an avenue that they wish to pursue?
Okay, this big question. All right. The way I see things is that MAID is another touch point along some people's journeys, right? That they may or may not embark on. It's different, but no different than other decisions that need to be made, like whether or not to embark on chemotherapy or to stop treatment or stop medications or to be ventilated or to stop a feeding tube or to pursue MAID. These are all big, humongous decisions that people are making along their illness journey. Okay, so the ripple effect, that one of the 7 keys, is acknowledging that when someone has an illness, they're in the spotlight. And when they make a decision within their illness, it has an effect on the people around them. And we'll just call those people their family. I call them their inner crew, because sometimes people don't refer to family, but the people who are wrapped around them will be affected by the diagnosis, by the decisions that you make, including if you make a decision to embark on MAID. I feel like the ripple effect and what that's going to feel on the people around you is really going to depend on that individual family dynamics, really, because we have people who choose MAID whose family is hugely supportive of that decision. And so there's going to be a ripple effect there, but it's going to look different than if you have a person who's choosing a medically assisted death and their family is all against it. Or you might have some family members who are and some who aren't, and every combination in between. So it's hard to say what the ripple effect will be on the family when someone embarks on the journey of exploring MAID. There will be a ripple effect, but it's going to be different depending on the composite of the family, the dynamics in the family, and the journey before the decision about MAID. So this is the part that I think needs exploring, is that I think a lot of the trouble, a lot of the negative ripple effect that happens for people is because we wait way too long to address and unpack and call out and learn, educate, inform, whatever words we want to use. We're waiting so long that this becomes a crisis. So can be a small ripple effect and there can be a massive ripple effect at that point. I don't know if you had any specific questions about MAID.
No, it was more just, as I say, for me, it was, in some of my sort of education that's coming into this role, and certainly, looking at some of the resources and just observing, as you say, there have been some people that are very supportive and have kind of gone through that journey and understand the rationale and the thinking. Some people that have been very supportive when present with that individual, but when away from that individual are struggling. So it's kind of that sort of I get a double-edged piece. What one is that they don't, they want to be supportive when facing the individual that's making that decision and saying, whatever you decide, I'm supportive of it, but actually that there's that sort of internally struggling with what that actually means. It was just some things that I kind of noticed, because it is a decision. But as you say, I think it's very true. It's part of that starting the conversation earlier, understanding the trajectory of the illness and what that actually means. And equally understanding that individual and what matters to them. I think, you speaking to the fact of hands, and here I am waving my hands around as well. These things are important. And so being able to have that conversation earlier on, being more informed about your journey, having that inner circle, sharing your thoughts and your directions to that, in my mind kind of helps to manage these things earlier on and have that more open dialogue earlier in that piece, so that you're not left in those sort of last month or whatever period trying to deal with all of this and unpacking it at a time when really you don't want to be doing that.
I can't tell you how many people have requested MAID since I graduated. They didn't use the word MAID because it wasn't coined yet, right? And it was illegal. But from the first week I started practicing, I have had people ask me for the pillow or the gun or the injection, begging me. And of course, I didn't do any of that. But what I did was I had to sit with people and try to understand where the request was coming from and try to attend to their suffering. And we would do the 11th hour scramble. We would talk about, okay, let's go over where things are at now. Let's go over what this is going to look like when nature takes its course. So many people assume that the dying process is painful itself. They assume horrible things are going to happen, and it's fueling people to ask me for the injection or the gun or the pillow. And when we sit and talk about the reality of what dying looks like, I can't tell you how many people have said to me, I never knew that. Are you kidding me? I just assumed this was going to happen or that was going to happen. And so, you know what? You can keep your pillow. You can, I don't need it today. And so many people, that request melted away. Again, this is a long time ago, but I hold that experience very close to my heart. And now I realize that all the more urgency to make sure that people have factual, honest, open information, because I don't want thousands and thousands of people rushing for MAID at this point because they're lacking information about what is going to happen or not going to happen, fueling their request for assisted dying. People who survive loved ones who have had a medically assisted death, I have been told, find themselves in almost like a disenfranchised grieving group, meaning that like they don't fall into mainstream grief groups because of this unique choice, that people are so divisive about this topic that the bereaved can't find themselves a place to grieve openly because they don't know what people are going to say about judging the decision that was made, or maybe they didn't themselves agree with it. So it is a unique subgroup. I don't want to say subgroup, subculture. It's a unique group that grieves in a way that I think isn't fully supported right now. I do think there are efforts afoot to find grieving communities for people who have lost someone by MAID. But yeah, it's new, huh, Teresa? Like we haven't had to grieve these people who have had MAID until 2016, so it's new and it's changing. The definition of people eligible for MAID is broadening. So we're going to have different groups grieving in different ways that we might not be ready for.
Mm-hmm. Yeah, no, I think it's great words. I think that's, as with anything that's new, we're always never fully aware of what the impact of that is going to be, and constantly learning. As you say, I think if we're improving education across the board around all of these things, then that helps to a degree. But it's also important to recognize, as you say, that in the same way that people grieve in different ways, there are these different groups, and we have to be able to understand that and support, as like an organization like us, be able to support all of these different ways that people grieve, acknowledge grief in these the different ways that might lead them into that in the first place. So it is, I think it's going to be an area that we need to better understand. And as you say, as the sort of the definition expands for MAID, it's going to increase that. It's going to increase the numbers and the different ways and the different types of decisions that are being made.
Yeah.
So, but no, thank you very much. No, I know it's a tough subject. But I think, again, in the same way, it's an important subject to talk about as well.
Yes, it's really important. Thank you for asking. Yeah.
No, thank you very much.
Yeah.
Thanks for joining us, Teresa. Sammy, I just want to share some thoughts from a few participants. One says, thank you, Sammy. I also love your TikToks. And are you seeing success with your mentorship and teaching with family physicians? And if so, can you share any tried and true approaches? We are actively teaching palliative approach to nurses and physicians and are feeling some reluctance or resistance to do this amazing work. As you mentioned, it is often left too late for our specialist palliative care team.
Yeah. Thank you. So I believe that it's difficult to sell. Some of my colleagues would knock me over the head for saying this, because we debate long and hard about whether or not the P word, palliative, is helpful or not helpful. Should we be calling it something else, or should we just call it for what it is? But what I was going to say is that, like I said before, when we try to teach family practices that they should be providing palliative care, for them, it's still a loaded word. And many of them will immediately, because they haven't been formally trained, say they don't do it because they're either scared of it or worried about it in some way. So I believe that if we use the language of family medicine, we will probably have a better time of it. So using language like, how do you care for people with a progressive life-limiting illness? I didn't say the P word. How can we help you learn how to care for those patients in the later chapters of their illness? What does comprehensive care look like for patients with this particular illness? What does continuous care look like? Like, family doctors are well versed on those words: patient-centered, family-centered. Like, I think we need to stop selling them something that seems very different than what they're actually been trained to do, if that makes sense. I think that's one approach, is to meet them where they're at with the language and the lens through which they see their patients, really. I did something sort of funny. I went on a roadshow to all these family medicine practices, and I asked them at the beginning, how many patients in your practice right now are needing palliative care? And they would say, and they had practices of like 2,000 people each. They would say, oh, I think 2, maybe 4, maybe 2 or 4. And so I was like, okay, I knew they were thinking of people who are in the last days of cancer. That's the prototypical person that they're thinking about. And then I did a big spiel about what's a palliative approach. It's person-centered. It's for all progressive life-limiting illnesses, da, 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 da. And then I resurveyed them at the end of the presentation. And I would say, okay, now answer that question again. Now that we've broadened our idea about palliative care, palliative approach, and who deserves it and who should get it, how many people in your practice now do you think you could identify as requiring a palliative approach or this type of care? Yikes, 500. So it's a mind shift for family practice to be broadening who requires a palliative approach. I think is the first step, is really just a mind shift.
Another question. Thank you for that answer. When you spoke about chronic patients, being patients living with life-limiting illness, I'm one of those patients, this participant says, and wonder, who do you think is responsible for organizing all the tests, blood work results, medications? I'm finding my care team doesn't communicate within itself, nor have I ever had anyone discuss advanced care planning or the palliative approach to care.
Yeah. Well, thank you for sharing and asking. I will say that there are chronic illnesses that aren't progressive. So I should probably say that. So for example, a chronic illness is one that you're going to have forever. So let's say I had psoriasis. Well, that's chronic, but it's certainly not progressive and life limiting. I might have arthritis of my knees. That's chronic and it can progress, but it's not life limiting. So I don't want everyone who's listening to fear that if they have a chronic illness, that every chronic illness is progressive and life limiting. What I meant was that we shouldn't call progressive and life limiting ones just simply chronic, not that it's simple, that there's a misnomer there. Anyway, to answer your question, I guess the provocative part of me says, be invited to be respectfully assertive yourself, and don't wait for this information to come to you and fall in your lap. Find your voice and come forward and try to get what you need from the healthcare system. I don't want patients to feel that they're going to be labeled as a difficult patient or not get what they need because they find their voice. That you have a right. It is your body. It is your illness. It is your future. You have a right to as much information as you need. Who is responsible for the healthcare side of it, arranging tests and medications and all of these kinds of things? Well, it's the healthcare system. It's the doctors and the nurses and everyone else. So if you feel that you're not getting something, or you feel you're getting lost or slipping through the cracks, step forward. Step forward and just ask those questions that you've asked me today to your healthcare teams. You can say, I'm worried that I'm slipping through the cracks. I'm just label it. I'm worried I'm not getting the information I need. I'm worried I'm operating behind the 8 ball here. I'm the kind of person who is sort of organized. I would say about myself, I'm a controlling person. I need this information. I need to know what the next step is and who's on first and who's on second. I want to be the CEO of my own journey. This is the kind of thing that we're trying to help citizens do, so that the healthcare system can't get away with stuff. So I want you to find your voice.
I think those words are important for not only our listeners, but just for all the people that we in the palliative world work with. And I'm really grateful for that. I'm also aware of our time, Sammy.
No.
Yeah, no, I know it's ridiculous.
I have a question though. I see hearts floating up. What is this? Is so cute.
Yeah, so our participants can give a reaction. So if they like something you've said, or it touches them in a particular way.
Look at their phone.
Yeah.
That's so cute.
And that's happened. You maybe didn't notice, but people were sending up their clapping hands sometimes when you were doing your presentation.
That's incredible.
Isn't that beautiful?
Feel like I'm gonna cry.
Yeah.
That's so cute. Thank you to everyone. I'm looking for a thumbs down. Is that a reaction?
Yeah.
Is that a possible reaction?
I think it probably is. You're not likely to get one in this group.
Thank you.
Sammy, we didn't get to all the questions, and to our participants, we just appreciate your input, and just know that we're sorry we don't have an infinite amount of time to explore all the things that you brought to us. This is a really important conversation. when 90% of us are going to come to the end of life in a way that we can see coming. And we do know that the current mortality rate among Homo sapiens is 100%.
Yeah.
One way or another, we are going to get to the point of actively dying if it doesn't sneak up on us in the night.
Mhm.
And so I'm very comforted by this conversation and by all of us in this room today that we're saying we're willing to engage this and we'll keep working at it. And we'll do it apprehensively sometimes with anxiety and courageously and joyfully. And there'll be little wins. And today's a win, a little win. Thank you. Let's see, you get about 1 minute and 37 seconds to sum up our talk, and then I'll close with a couple of announcements.
Okay. I think I just want to tell people that any news is better than no news. So have the courage to seek information for better or worse. Many people feel more grounded, even if it feels upsetting and there's emotion related to seeking real information. We are incredible people. You will likely adjust and then be able to move forward. You cannot plan and move forward and feel grounded and in control if you don't have information. Get yourself out of the twilight zone and just go for it. You will feel better with any information, for better or worse. That's been my experience with all of my patients. They say thank you for anything. So go for it and get it. You deserve it. You have the right.
Thank you for that.
Yeah.
Well, we are coming to the end of our time, and from all of us at the Palliative Care Society of the Bow Valley, thank you, Sammy, for the gift of your time with us in a very full career life. And thank you to all of you who took time out in the middle of the day, or if you're watching this as a recording, I'm glad you found some time to sit with us and to join this conversation. Here in the Bow Valley, if you are wanting to access palliative care in addition to what your home care and doctor are providing, PCSBV provides emotional and social supports and navigation supports through our volunteers and through myself as a practitioner. And if you're looking for grief supports, please don't hesitate to reach out to have conversation with me or to join one of our programs. So be well in your day, all of you. We send you off with love and light and engaging a really delicious conversation. Thank you, Sammy. Be well in your day.
You too. Thank you.